Okay, this actually won't be very much of a workshop because I know you're pressed for time, so unfortunately it's going to be perhaps a bit more of a lecture. We talked about practical patient safety and what this means for us as doctors, rather than what the NHS seems to think of. They talk about zero harm admissions being no catheter-associated urine infections, no falls, no VTE, but there's something far more important than that about patient safety, I believe. So I wrote a paper called What is Quality and Safety at the Point of Care? This was back in about 2010, and described what I think the work of my inpatient team is on the general medical wards. So the work of my inpatient team is to swiftly, effectively and safely treat acutely ill medical patients and get them ready as early as possible to safely resume living outside hospital. A small proportion of our patients, our work is to anticipate end of life and help to ensure a calm death. And we also work to train the next generation of healthcare workers to better our performance. So I summarise that as the right diagnosis, the right treatment, at the right time, in the right place, with the right to no avoidable harm, and better next time. So we take the patients that we're looking after, we hand them over from the general practitioner to the hospital, back to the up to the wards, back down to the general practitioner. We've got to make sure they're staying safe up there on that dangerous traverse through a hospital stay. And if they fall off, it would be nice if we can keep them safe rather than they fracture their neck or femur as they fall. But if they're falling to their death, it would be nice if they gently fell to their death and landed comfortably and died comfortably. So the patients aren't safe if we get the diagnosis wrong. They aren't safe if we get the treatment wrong. They aren't safe if the treatment is delayed. They aren't safe if the treatment is in the wrong place. So Dan Beckett at Forth Valley, he has evidence that if we board patients out or they're outliers in a big hospital, maybe one person in 40 dies only because we put them in an outlying ward with the wrong team who don't have the expertise to look after the patient. Now, even if it's 1 in 100, that's still an extra 1% on hospital mortality if we're boarding patients out. So the right place is important. The right to no avoidable harm, so we don't make medication errors, we don't knock the patients over and make them fall and have a fracture. And then a bit about, I've been involved in medical education for a long time. The board round and the work at the hospital is for training doctors as well. It's to make us better next time, and I want the next generation of doctors to be even better than I am, because they might have to treat me when I'm ill. So teaching and training is inherent to the practice of medicine, to my view. I don't think we explain to the public and to our hospital managers maybe what we do in medicine, and this is what I call the clinical care cycle. And we usually start at the top, where we hopefully know the patient's comorbidities from the referral letter or from the emergency care summary, and then we try to establish a diagnosis, which at first we may label as an impression or a working diagnosis, and then we come up with treatment plans, deliver the treatments, decide what monitoring we're going to do, and then review the patient's progress. And what started as perhaps a working diagnosis at the top, by the time we've been round it 3 times, has become a clear diagnosis, and we know what we're doing. So a lady up on the ward came in with her working diagnosis was she's extremely unwell, it looks like sepsis, and we better treat her with triple antibiotics. And after 3 days, it was clear that the problem was a liver abscess. And that's how we work. We go through from a working diagnosis until we're more certain. But we still don't know why she's got the liver abscess, so there'll hopefully later on be an answer as to why she's got the liver abscess. And we go round and round and round that until the patient's either improved sufficiently they can leave hospital, they may not have resumed their previous health, or they go round and round, deteriorate and die. And those are really the 2 outcomes that happen in hospital. The patient who arrives really unwell in resus, we're starting treatment before we've got the diagnosis of the comorbidity, so we can buy some time then to do some clinical thinking. Right, here's a tiny little bit of workshop for you. Don't get pens out, don't get your cameras out, apart from Billy up there who's videoing this. I want you to remember these 10 items, and to help you, I'll read the 10 items out. They've got a Viking theme, as you can see. Coffin, smorgasbord, sword, amylase, CT results, longboats, and electronic record. Got that? Benjamin Franklin, who helped to write the American Constitution, said if we fail to prepare, we're preparing for failure. So if we prepare for our work, we're preparing for success. I spend a lot of my time preparing even before I go to see the patient. I'll read the emergency care summary, I'll go on to Sky Store, I'll get the information about the last clinical consultation and get an idea in my head about what other doctors think has been wrong with the patient. That's not to give me the answer, it's to tell me the things I've got to treat with respect, but be sceptical about. And I think if you don't prepare for that, it's a bit like heading off to play in an orchestra when you've just got the notes in front of you, you hope you're going to make it all the way through, but you haven't actually read the whole score. So I believe that we should be preparing for diagnosis and preparing to get the diagnosis correct. Quickly go through these two patients and then one patient where things worked out really well. This man on the left-hand side of the screen there, as you can see, has got a red hot swollen knee. And he arrived on a Thursday evening in our hospital in the south coast of England, and people thought he probably had sepsis. A week before, he'd had some treatment in a cancer centre 30 miles away, as the crow flies, for some problem in his bladder. When I went through our notes, in June he'd been referred for possible hot mitomycin treatment in his bladder. And there the information trail went completely dead. There was no information back from the cancer centre. He confirmed his GP hadn't had any contact either. He couldn't tell us the name of his consultant and he didn't know what treatment he'd had. But they put something into his bladder. So overnight he was treated with triple antibiotics. That happened to be the day when Don Burke was visiting our ward rounds. And we said to the registrar, what are you going to do then? She said, well, I can't do anything other than keep him on the triple antibiotics over the weekend, hope he gets on all right, and we'll phone the cancer centre and see if anybody can tell us what's going on. On the Friday, we got nothing. A week later, the Thursday, a week later, we managed to find out who had been treating him and what his problem was. And he had had attenuated BCG put into his bladder for a superficial bladder tube. So I went back to say, at least we know what treatment you had. And he said, oh, doctor, a couple of years ago they did that to me and I got this really sore knee and I felt very unwell. And he had some sort of immune reaction to the BCG. So we gave a complete misdiagnosis, complete mistreatment for a week because the information was lacking. And this shows these days that having the information readily available, accessible, laid out in a format that can go into our brains is essential for the right treatment of the patient. He could have got C. diff diarrhea, he could have got MRSA, he could have been made deaf with the wrong dose of gentamicin, and we completely mistreated him just because we didn't have the information. So our colleagues in the IT department, Billy, are really important. These people should be able to extract the information that exists and put it into a digestible format where it's fed into our brains. Junior doctors know the commonest thing on a handover is chase thee. You've got to go as a hunter and a gatherer to find the information when the information is all there already and should be presented to us, laid out on a plate, ready for us to eat into our minds. The patient on the right came into our hospital with aortic stenosis and severe cardiac failure, put on about 13 kilograms in weight in 2 weeks, and was very breathless. On the morning handover, the nurses said last night when he was drinking his glass of water, which he likes before he goes to bed, the water came out of his nose. So I thought, maybe his left atrium's enlarged and it's pressing on his esophagus and the water's coming up that way, or maybe it's just a tall story. So I went and sat with him, and we'd got him to drink a glass of water, and he'd already had porridge and haggis and fried eggs for his breakfast, and they'd all gone down fine, and the water went down fine, so I thought, nonsense, we just told a story. Next morning, the same story. Water had come out of his nose. Junior doctors then went back through all his notes, and read his notes. About 2 months before, he'd been to an ophthalmology clinic who complained of double vision. They'd done the acetylcholine receptor antibody, which was positive. They hadn't seen that result, nobody had acted on it, and he had myasthenia gravis as well as severe aortic stenosis. So again, a misdiagnosis, a delayed diagnosis, just because we didn't know what had been going on with the person before. Now, surgeons. So we're back into your land now, and this is a story. Where's Ella? Here. Right, this is Ella's story. I hadn't been here very long when a man was here from Japan with his family and had come to Oban because of the wonderful seafood you get in Oban, and he sat down in a restaurant over there early in the evening and with his first mouthful of food got severe abdominal pain. We went off to the bathroom, we vomited in the bathroom, we came back into the restaurant, collapsed in a heap on the floor, where the restaurant owner dialed 999. They quicked him up to our A&E, where Ella was on her way home, and I happened to be down there doing something else, and they grabbed me as a physician, which isn't a very smart thing when you've got somebody with acute abdominal pain. And I went to see this man, and he looked really ill, properly ill. His vital signs were okay, but he looked very, very ill. So being a physician, I thought there are some things below the heart in the body, like has he got a dissecting aortic aneurysm, has he got an intercostal hernia, a twist there, has he perforated his duodenal ulcer, perforated diverticulum, turned him over, see if he'd got a tender spine. And I'd run out of ideas and he was looking really sick. So gave him some fluids and some morphine and phoned a friend. And Ella said she'd just got home, but she turned the car around and came back to the emergency room. And I think she spent about 8 minutes with the patient, as far as I can remember. And I said to her when she came out, so what's wrong with the patient? I said, what's wrong is that he needs to go to the operating theatre. I said, well, come on, you're a surgeon, you've got to know the amylase and you've got to know the CT scan result. She said, no, we're going to the operating theatre. So I think by the time we got to the operating theatre, we got his amylase back and knew he didn't have pancreatitis. And I would decide to go to the operating theatre because I hadn't been for 30 years. It'd be a nice way to spend the evening. And I could probably leave Anna running the hospital rather than me having to run the hospital, which is too scary for me. When you open the abdomen, there's sort of pinkish fluid poured out of him. And then opened up the incision, and inside was a lot of nearly necrotic small bowel. And all this small bowel would pass through a hole in the omentum, then strangulated and looked very close to necrotic ischemia, very ischemic. So somehow he pulled all this bowel back and sewed the hole up and looked at the bowel, and it looked as if it might be viable. And he was well enough then to be sewn up, and David kept him alive with his anaesthetic, and we transported him down to Glasgow in a helicopter being ventilated, I think. 2 days later, they had to remove most of his small bowel. And he was left with 70 centimetres of small bowel, and which was enough for him to eat, and he's gone back to Japan. What struck me there was Ella's huge expertise in being able to assess this man. The diagnosis was only he's really ill and he needs to go to theatre. My diagnosis was he's really ill and he needs a surgeon. And I don't know if we could ever have predicted that. Well, it was a surprise to us when we did it. And you can make a very good diagnosis, particularly in rural medicine, when you've got very little information to go on, but just your expertise of knowing when to act and how to do it. And last night I heard similar stories of surgeons who, with very little information, able to make a decision to proceed to operation. If that had happened in Worthing, he'd have been seen by the triage nurse, he'd have been seen by an A&E SHO, he'd have been seen by the A&E consultant, he'd have been sent to X-ray, might have had a CT scan, the report might have taken a while, and he'd have been dead, because his bowel would have been dead by then. So you need to act, as you know, you need to act very quickly once you've got a good diagnosis. So, if we get the diagnosis wrong, it's really unsafe for patients. There's a big movement at the moment looking at how we make errors. What happens? How do we get it all so wrong when it's so bound or obvious what's happening? The people who look at diagnostic error always look retrospectively. They know there's an error, they look retrospectively, and they only ever look at the notes. And the notes aren't what happened. They aren't the consultation, any more than a teacher's notes at the end of the lesson are what happened during the teaching. There's also a lot of retrospective bias. If you tell people to look at a video of the consultation and tell them the consultation worked out fine, and tell another group to look at the consultation and tell them it worked out with the patient dead, the group who looked knowing the patient died find twice as many errors in the consultation as the group who were told the consultation worked out fine. So these people looking at diagnostic error are looking at retrospectively, and they know errors have happened and they can tell us all the things we did wrong. Also, a bit about misdiagnosis, we don't know the denominator. Maybe we're actually doing as well as we can. If we don't know how many consultations go wrong and end up with a misdiagnosis, compared with how many go right and get a correct diagnosis, we don't know the denominator, so we can't know whether they're getting better or worse. And if the best diagnostician in the world got it right 98% of the time, there'll be 2% diagnostic error. They also don't actually know what they're talking about when they talk about the diagnosis. I could see them looking stunned last week when I was talking in Switzerland, I said, is it the admission diagnosis, the reason for admission, the diagnosis at 24 hours, which Dr. Foster uses? Is it the working diagnosis? Is it the final diagnosis on the discharge summary, or the post-mortem diagnosis? And of course, we don't do post-mortems these days, so how do they know we got the diagnosis wrong when they don't know what the patient died of? I don't know. There's also a bit about how your activity is coded. So a patient comes into hospital with cardiac failure, COPD, and a bit of pneumonia. If they're admitted under the cardiologist, the diagnosis will be cardiac failure. If they go under a pulmonologist or respiratory doctor, the diagnosis will be COPD. If they go under a geriatrician, it'll be dementia and pneumonia. They're all true, and that's all what we're contending with. But the people analysing it might say, well, two of them got the diagnosis wrong. But we do know that if misdiagnosis happens, and it can be harmful or lethal. And people in this country are well aware of cases like Bawagaba, and then just in the news today, a boy in Manchester who died that seemed to people saying is avoidable. So we know misdiagnosis happens, it can be harmful or lethal. So coming back to this idea of what's happening in the consultation, we all know, and particularly in rural medicine, you know, that diagnosis happens in your brain whilst you're talking with the patient. So I think it's a bit like going through a maze. You could rig somebody up with a GPS system, and you could work out where they turn left and where they turn right, and you could tell them where they went wrong, particularly if you afterwards can have a video camera on top of the maze. You can luxuriate in thinking, look how silly they were, they went the wrong way. But what you need to know is what's going on in the brain of that person as they go through the maze. And I think diagnosis is like a maze, and it's far more complicated than that. It's like the Crystal Maze program. It's a 3D maze, and you're trying to go through, often with a team of people, and half the team's going off the wrong direction. Somebody else has wandered off by himself, and somebody else has actually got right to the centre already. But the retrospectoscope allows you to stand above the maze, see where everything went wrong, and you've got all the time in the world, whereas we had, with Ella in that case, we had 3 or 4 hours to get the person to theatre and get it sorted out, or else he was dead. So what we're doing, I think, when we're interviewing our patients, examining the patients, is attentive listening and clinical reasoning simultaneously. There's a little mental maths sum. So if you're doing a mental maths sum, it's all in your head. You've got to get the diagnosis right. If somebody looks at the wrong answer, they don't know what's gone in your head, wrong in your head to get the answer wrong. So this is what we do. There's no notes there. Well, on the right-hand side, there are some notes. You're listening to the patient, paying attention to the patient, picking up all sorts of visual cues, thinking in your head at the same time what's happening. And it struck me a couple of weeks ago, I've never told anybody what happens in my brain whilst I'm doing a clinical consultation. All of us, I suspect, sit or stand at the bedside, looking very calm, as if everything's under control. And an observer would just think, he's standing there, wondering when his lunch is, I suspect. So I'll come to a bit about what's going on in the brain. And a bit more about our limited brain RAM. Why weren't the doctors writing the notes? Why do you turn the radio down when you're reversing the car or turn it off? The reason they weren't writing the notes is because attentive listening occupies a lot of your brain's RAM. And most human beings can't even do attentive listening. Whilst you're doing that attentive listening, you're doing clinical reasoning. And that is really high level stuff. And the human brain actually can't multitask. So what you're doing is switching very quickly between attentive listening and clinical reasoning. So the patient says, oh, the pain was here, and you think, well, that sounds like angina. Or the pain was down here, and then it was writhing around with pain, and you think it's a femoral hernia. So those are two really high-level things, and most human beings can only do one high-level thing at a time. So then if you ask the doctor to write the notes or type on the computer or try to find the troponin result or the X-ray result at the same time, our brains failed. And the reason you turn the car radio down whilst you're reversing is because reversing is an unusual thing to do. You need a lot of brain RAM to do it. And if you're listening to the music as well, you can't do it. So a very simple illustration that everybody knows you turn the radio down whilst you're reversing should reflect on what we're doing in ward rounds and diagnosis in ambulations. Our brain has limited RAM. This computer of mine is pretty useless. It's got 4 gigabytes of RAM. I could go down there, buy another 4 gigabytes, put it in, and maybe it will work nicely. We haven't got another 4 gigabytes you can put in. Also, if the battery runs out on that, I can just charge it up and use it at the same time. You can't use your brain and recharge it at the same time. There's a human limitation. So we don't have two brains like Steve Martin in the film The Man with Two Brains. If we did, it would be wonderful. But perhaps we do have more brains than that. I want a ward round with 3 doctors and a nurse. That's quadruple the amount of RAM that's available for doing the work. So what, I don't know. It'd be interesting to know what goes on in your minds, and if you'd like to type it up and tell me, write to me later on, that'd be great. What's going on inside the doctor's brain in the maze of diagnosis? I never like PowerPoint slides that got lots of words on them. I'll come to that in a moment. Write down those 10 items then. Who's got the 10 items? Anybody got 8, 9 items? Okay, yes. Smorgasbord and a longboat.
Families. Yeah.
So we're only 7. Yes. How can I get you to remember 10 when there are only 7? That's what it's like when the patients come in and the information's out there and we can't even see it. We're bound to get the diagnosis and the context wrong if we don't have the information. Also, none of you could remember those 7 things. We're probably about 20 minutes into this talk. Often, you'll talk about a patient in the doctor's room, and 20 minutes later you arrive at the bedside. My patients, on average, have 8.5 diagnoses or comorbidities. So if we talk about the patient 15 minutes before and get to the bedside, is it any surprise we've forgotten the list of patients with problems, or we're talking to the wrong patient because we've got in our head that this is Mrs. Jones, but it's actually Mrs. Smith, and we're talking about Mrs. Jones's problems. So having lists and things like this is all very good, provided you can see them or hold them in your brain. But I've just shown you can't hold even a simple list of 7 things in your brain. So there they were. Coffee, smorgasbord, a missing item like the acetylcholine receptor antibody, sword, amylase, CT results, longboats and electronic records. 2 things missing. We didn't know what was wrong with the guy who had the bladder cancer. But even if you could remember them, well, you can't remember them even if you wanted to. Beyond the human brain's limitations. So here we go, this is what's going on in my head when I'm standing by the patient, or more often sitting by the patient, eye to eye with the patient. So imagine we've sat in the doctor's room, we've prepared for a consultation. Anna's told me that the patient's got COPD and a bit of pneumonia. There's also a type 2 diabetic and the blood glucose is high. So if I'm the consultant, this is the sort of stuff going on in my brain whilst I consult with the patient. Wow, she looks very thin. She's got plugged tar-stained fingers. I wonder if she's got lung cancer as well. Have I introduced myself clearly? Got a good rapport going. This could turn into a tricky consultation. Oh, she's mentioned a headache. Maybe she's got metastases to the brain or temporal arteritis. Have we measured the ESR? And did we even look at the chest X-ray? Now she says she hasn't been outdoors for 6 months. She could be vitamin D deficient. Will we measure the vitamin D level or just prescribe some? Maybe she's already on vitamin D. She was on the long list of meds. Why is the student looking for them? I'll ask him to look at the meds list and the F2 can look for an ESR. Now, should I go on to the high glucose problem or the pneumonia next? Oh, her husband's arrived and he looks angry. Where's the nurse gone to? I need her to hear the whole conversation so she can calm the patient and her husband down after I leave before this turns difficult. And I must remember the medical director said we're doing badly on VTE and dementia forms and looking for pressure risks, and the 4-hour target is going badly. So could I discharge the lady today and do all her investigations as an outpatient? And down, there goes Henry the Hoover. The F2 has had to answer a bleep, and PAX has gone down, so we can't review the chest X-ray. Now, how many years have you smoked for? Well, that's what it's like for me, however calm I look from the outside. And that doesn't need any residual reasoning capacity for, could her weight loss be from an overactive thyroid, or from badly fitting false teeth, or depression, or because she drinks a lot of alcohol and eats no food. Now, since I've said that 2 weeks ago and met other physicians, most people say that's the sort of stuff that's going on in their brain. That overloads your RAM. So we're expected to be as sober as judges. Judges are very sober people, they're a bit like us as doctors. You interview a judge, he says, yes, I always make the same decision based on the same evidence. I'm completely uninfluenced by extraneous factors. And if I sit all day and hear court cases, I'll still make damn good judgments. So that's how we talk as doctors. Doesn't matter, I've been working 13 hours, I'm still in there, I'm still making such a good diagnosis, I'm never making a mistake. It's all the other people in hospital who make mistakes, it's not me. So, if you're a parole judge, the difficult decision is to let somebody out, because it's risky. Let them out in the community, they might murder somebody at lunchtime. Keep them in, it's nice and safe. These peaks of them making the difficult decision are after breakfast, after coffee, and after lunch. If the judges didn't eat breakfast, they didn't give people parole. If they didn't stop for coffee in the middle of the morning, they didn't give people parole. If they didn't stop for lunch, they didn't give them parole. Same happens with your grant applications. If you put in a big grant application, you want megabucks for a study on rural medicine, get the application heard straight after lunch, because you'll probably get the application approved. So when I saw that, I started changing the way I did ward rounds. I used to start at bed 1 and go to bed 26, and I went to bed 1 to 26 one day and 26 to 1 the next day, and then tried to remember to start in the middle of another day, so that people weren't getting the raw deal. And I suspect that this happens to us. The things that can overfill our RAM, the nurse coming in asking me to prescribe paracetamol halfway through a consultation, the cleaner with Henry the Hoover, the bed manager coming in and saying, why haven't you done the TTOs? Lots of noise, distraction, trying to find the chest x-ray, the ECG, the troponin result with potassium in a patient with chest pain. The effort of finding those distracts my brain. Quite as well as doing all that juggling that's going on in my head in any case. So it's very easy for our RAM to get overloaded. How long do our batteries last? How can they be replenished? It looks from that parole judge thing, it's about 2 hours till our batteries are exhausted. So you need to Alt, Control, Delete, wipe your brain clean, and have a proper refreshment. They're talking at the Academy for Medical Education in Europe that the zealous doctor is a danger. And I could immediately think of some of our juniors who at 5 to 2 are still down in A&E. Lunch has been running from 12 till 2. If it's 2 o'clock, they've missed it. And you can't get them to go because they say, well, there's 6 more patients in A&E. They may be more of a danger to our patients than the average doctor who goes away and makes sure he has 15, 20 minutes break, because their brains will be exhausted. In NHS England, I think most doctors have given up the idea that the NHS might be interested in looking after you, but the hospital executive team should at least be interested in looking after doctors' brains, because that's where all this stuff's going on. So they should be thinking, how would you look after a doctor's brain and keep it functioning maximally well? And since I came to Oban, I'd say Oban Hospital really looks after doctors' brains very well. We have really good places for lunch, we have a nice lunch break, we've got a good view, there's nice surroundings, and people seem to expect you ought to stop for coffee and you ought to have a break. Some of the things that I do to look after my brain are pre-preparation. So this thing on the right is very much like your operating theatre checklist of your surgeons. Just a simple record. How did the team function overnight? Did they get a break? How many patients have they got for me to see? How many patients are ill? How many patients might go home? Just mentally prepare for the ward round, as well as saying, well, what's going to happen if something goes wrong? So if there's a disaster, I'm no good at dealing with disasters. The registrar will deal with the disaster, so if the cardiac arrest bleed goes off, the registrar just leaves without us all looking and thinking, well, what's going to happen now? So pre-preparation for the whole business of a ward round and all that decision making. As I say, I spend a lot of time preparing for outpatient consultations and inpatient consultations, trying to get the background to the patient, all this information into my head, even before I go to see the patient, and then go to see the patient if something doesn't fit, I can question it. So somebody says they've had 10 myocardial infarctions, and they're sitting looking absolutely fine in bed, and they're only 35 years old and haven't got a hint of cardiac failure. It would make me wonder whether they really had 10 myocardial infarctions. So this sort of pre-preparation, so I know what's likely to happen on the ward round, know what I've got to be sceptical about, and the same in outpatients, and I share this information now with patients. So this one on the left, I have on a tablet PC, and I can sit at the patient's bedside and say, right, you came in with cardiac sound and chest pain, you have type 2 diabetes, a high cholesterol, you're on donepezil because you have memory problems, and you can just work through it like that with the patient, which the patient usually says, it's a surprise, I'm alive, isn't it, doctor? And this one in outpatients, share on dual screens, duplicate screens, So again, you can just say to the patient, you've got type 2 diabetes, ischemic heart disease, you've had stents in the coronary arteries, and the patient is very smart and says you've got empagliflozin listed twice, and I might be taking 10 or 25 milligrams. And patients seem to interact with that screen much more than they interact with me in the sense of corrections. I think they're happy to correct the damn computer, but they won't correct the consultant. So I get a lot more interaction with the patient saying, no, I never had a coronary artery bypass, doctor. They would put me on the list, but they never did. No, I've just got stents. You can correct the information. This is exteriorizing tasks from the RAM. So whilst you're trying to remember those 7 objects in your head, you couldn't do anything else. So the more you put stuff out of your brain RAM into the environment, it frees your mind, empties your brain for attentive listening and clinical reason. So if I say on the ward round, and I want you to look at the meds list today, listen to the diagnosis and what we're talking about, and give me a report on anything to do with the meds, that takes a whole chunk of stuff out of my brain, that somebody else is doing it, and I can then carry on and concentrate with the patient. I developed a checklist for ward rounds. We let our year 1 doctor do a ward round one day. She saw 25 patients, did 25 consultations in one morning with the support of a registrar, myself, and 2 SHOs. At the end, she said, I didn't know if I did it all, and that was on a Monday. By Friday, we had a checklist to make sure we did it all for our patients. The first time I had that checklist done whilst I was doing the consultation, I felt an immense sense of relief. It was a difficult consultation with a patient with breast cancer and coming near to the end of her life, and she didn't know that, so it was a complicated consultation. And I knew that somebody was watching, and then would say, did you see whether she got a cannula that needs to come out? Has she got a catheter in that needs to come out so she doesn't trip over the tubing and fracture her neck and femur? So having somebody in the team who's watching out to make sure that everything's done, again, frees the RAM up for clinical thinking. Sometimes I get the junior doctors to do what I call a reverse role ward round. I say, you're going to do the consulting today, and I'll watch, or I'll do one patient, you do the next. I've learned all sorts of things from that. Wonderful interview techniques our junior doctors have, ways of talking with patients, explaining things to patients, but also it frees my mind to think. So I've made diagnoses in patients in that role that I would never have made if I was right in the middle of the consulting. So you can trust your juniors, and they're really good. You all know, as doctors you get usually in rural hospitals, really good junior doctors. They can do the stuff. Get them to do the consulting. That can free your mind to think again about diagnosis, case management, teaching, development of the junior doctors. So reverse role ward rounds. So make all the others do the work, and you can stand back and have fun. I didn't know you could get infection inside an EVAR, inside an aneurysm repair. And I saw the junior doctor examining the patient. I thought, I wonder if you can get an infection in an EVAR. And so I said to the junior, I wonder if you can. She said, I don't know. We went down to radiology. They said, yes, you can. They did the CT scan. And 2 hours later, she was on her way to the vascular surgeons. I never even knew you could get that. But because my mind had been freed up to think, I was able to do that. So I think the whole clue to avoiding misdiagnosis is not understanding cognitive bias and all these other things that misdiagnosis doctors and experts get very interested in. I think it's to do with exteriorizing tasks from our brain's RAM. Get the other people to do the work. Eradicate the distractions. So I can remember in Worthing Hospital about 2004, I was doing an audit on noise and interruptions on ward rounds. I presented it to our chief executive, and he said, first of all, you doctors are terrible, none of you got standard processes. 10 doctors turn up in the acute unit as consultants, you do the ward round 10 different ways. Get yourselves sorted out. I'm still working on that. But I said to him, I can remember on that ward round that I was trying to listen for an aortic regurgitant murmur. I banged my head on the overhead television screen. The patient answered the bedside phone whilst I was auscultating the heart, and the cleaner was buffing the floor around my feet. And I didn't realise at the time, but that chief executive took all the televisions out of the acute medical unit, took all the bedside phones out, and moved the feeding programme to the afternoon. And that's to help us think. Valdemar in Sweden, just north of Gothenburg, he decided that it would be a good idea to make 3 ward round rooms on the ward, and he made those rooms into private rooms that the patient would come to for the consultation. I went to watch that. I watched one consultation. I thought, this is something completely different. The patient was talking, the patient's in control of the consultation is completely uninterrupted, and you don't need much IT kit because you don't need it at the bedside because the patients come to the room. He gets 75 to 80% of his patients to come to the room. Wow, and that must free up his mind for thinking, and certainly gives a completely different adult consultation compared with us towering over the bed and the patient saying nothing. Other ideas I've got to improve diagnosis. If you see this person in the middle, and these two on the right, they're obviously not going to have a good conversation. It's very standoffish, very antagonistic, they haven't shaken hands, they don't know who each other are. I was only talking yesterday to our Dundee students saying, if you want to get a good diagnosis, start by asking the patient some simple questions to get them talking, questions they can easily answer. How old are you? What is or was your occupation? What do you enjoy doing these days? What are your interests? That makes the patients open up and talk to us. It increases the trust. They talk to us more clearly. If they talk to us more clearly, the diagnosis goes into our heads. If the who are you, what are your interests, what's your life all about, is page 4 of the clerking pro forma, that makes it look like we're just looking for mesothelioma and people that handled asbestos. We're meant to be doing, I want to do, personalised, person-centred here. So start with the person. So unless they're unconscious in the emergency room, I start with that with every consultation, every patient. And I think it leads to better diagnosis. Certainly makes medicine much more fun. Other things I've done to try and improve diagnosis, if we can recognise the patient's ill and we don't know what the diagnosis is, then we should stop and think. This is moving from quick thinking to slow thinking. And there's a list of questions. You can see it on the bookmark for better care that I've put out for you. Interestingly, again, the Association for Medical Education in Europe meeting, the evidence is that we don't realise it's a difficult patient where we've got to stop and think, and we're not reliable at that. So we may be let down by that because, first of all, we don't realise it's a difficult patient, we've got to stop and think, and then we don't think it through. On the right is something called Isabel Healthcare, developed by Jason Maud. His daughter, Isabel, had chickenpox and got a very rare complication of chickenpox. He was surprised how long it took doctors to make the diagnosis, so he gave up his career in international finance and wrote Isabel Healthcare. Those are the 3 diagnoses in the Babagaba case, where Jack Atcott had fever, diarrhea, and acute kidney injury. And apparently we were meant to know from that he had group A streptococcus causing pneumonia. Because the paediatric expert said that's what everybody would diagnose under those circumstances. And of course, group A streptococcus actually doesn't very commonly cause pneumonia in any case. But it's a very good application for getting you to think through things, and particularly to think, well, it's definitely not that. And I've never heard of that, I'll just go and read up on that. Tony Miles, Tony Miles, your friend, he liked to get the junior doctors to give 3 feasible diagnoses on every case. So even if it was barn door obvious appendicitis, he still wanted them to say it could be pelvic inflammatory disease or Bilharzier of the bladder. Now, I tend to like to say to people, what's the most likely? So it's severe cardiac sounding chest pain with vomiting. Obviously, most likely to be myocardial infarction. What would be the most dangerous? Dissection of the thoracic aorta in the absence of an aneurysm, maybe Marfan's or something like that. Rare but feasible to have Borhardt's syndrome. Now, if we're thinking like that, maybe it's like a weightlifter who lifts weights on the days when it's not the competition. So he's absolutely ready for the competition day. So if we're thinking that with every patient we see, Mike helps us mentally agile for the difficult cases apparently we don't recognise, but at least we'll be thinking of the diagnosis. Back to Sweden. Oh, it's all Swedish. Fika is a Swedish tradition of coffee and cakes. And when I went on that ward round with Valdemar, we met at 8:30. There was this lovely smell of coffee. It was a nice relaxed room. We had the night handover from the junior doctors. We went and saw 3 or 4 patients when it's Friday, so it's 11 o'clock. Have fika with the nurses. See 3 or 4 more patients. It's Friday. Stop and have lunch with the chief executive. So fika is a system in Sweden that protects against misdiagnosis and keeps doctors happy. So I would argue that in relation to patient safety, correct diagnosis, that probably learning to be Swedish is the answer. Because then we'd stop every 2 hours, we'd wipe our brains clean, refresh body and mind and soul with refreshments, because that's what refreshments are, they refresh you, and then we might get away from so much misdiagnosis. So 70% of diagnosis happens in the consultation. In rural medicine, it's probably 80 or 90% because you don't have access to all these tests. We need people to take care for our brains. I had this idea that we could give hospital executive teams one of those Tamagotchis, and it would be called Doctor's Brain. And 2.5 hours into the chief executive's nice meeting up in the management suite, the Tamagotchi would start beeping and say, your junior doctor is about to order a PET scan, this will cost £100,000 and it's not needed. Perhaps you ought to give her a coffee and cake.